Good afternoon, folks. Today at this Northern Science Festival, we have Dr. Suzy Lishman. She's a consultant histopathologist at Peterborough City Hospital, quite a tongue twister, and a past president of the Royal College of Pathologists. Today she'll be presenting her talk on Tools of the Trade as part of her Living Autopsy Event Series. During this digital lecture, Dr. Lishman will explore the process of post-mortem examination: who, what, why, when, and how. Suzy, thanks so much for coming to the festival.
Thank you very much. Thanks for inviting me. I'm delighted to be here. I'm sorry I'm not there in person. I'd love to have, I was looking forward to my trip to Belfast, but unfortunately it was not to be, but hopefully another time. So welcome everybody. As you've heard, I'm Suzy Lishman. I'm a pathologist, and I'm going to talk to you a little bit about what I do. I'm going to show a couple of slides, and then I'm going to talk to you just face to face like this, and then I've got a few more slides to show you at the end. So please don't worry that it's going to be a lecture as such. It's not. It's going to be a friendly chat, and I'll just try and turn that in. Okay, so hopefully you can see that. So this event is the first in a series celebrating the Diamond Jubilee of the Royal College of Pathologists, which oversees the training of pathologists in the UK to make sure that they're good at their job. And I'm doing a tour all over the UK. This is the first one, as I mentioned, but I'll be off to all parts of England, Scotland and Wales as well, but delighted to be starting here in Belfast. And so the first thing I'm going to say is I'm going to talk to you today about autopsies. So that's examining the dead. And I am doing this at home from my living room. But obviously, normally in real life, I would be doing it in a mortuary. And this is what a typical mortuary looks like. And in England, we use the word mortuary. In America, you'll have heard on sort of crime films, they say morgue. But that's not a word we use in the UK. We call it the mortuary. And this is what a modern one looks like. You can see metal tables, they're easy to clean down. And then at the back, all those doors, they're the fridges where the bodies are stored to keep them cool. And they open and then they roll out on a trolley and are put out onto those tables. And I'm not currently wearing what I'd wear to do an autopsy. This is my friend Mike, who is modelling what we would normally wear. So we don't wear our normal clothes at all. We would put on scrubs, you know, sort of blue or green, like pajama-like things that you see doctors wear all the time. Then we'd have a gown over the top, and that tends to have a waterproof coating so that if anything, any fluids drip onto it, then they'll come right off. Then you can see we've got a plastic apron over the top of that. And then on the sleeves, you can see those white bits of sleeve. That's another plastic arm protector because your arms are the things that tend to get lots of blood and things on them. Then often 2 pairs of gloves in case you cut yourself. You're more likely just to cut the outer pair, and hopefully the inside pair will protect you. And then a pair of Wellington boots to keep your feet dry. And the thing that as pathologists we all learn very early on in our training is to make sure that that apron is outside the boots, because not great if it's on the inside, because everything just slides down and into your boots. So I'm going to close the slideshow now, because really everything else I'm just going to talk to you about. So the first thing before I start is to give a health warning. Now, I've got no dead body, no real body parts, no blood or anything like that. But I know from experience, having done quite a lot of these talks, that sometimes people's imaginations are so vivid that they feel a bit queasy or a bit faint from the descriptions that I'm going to give. You will probably know whether you're a queasy sort of person or not. If you don't feel well, please say so to somebody sooner rather than later. Much better for you to step outside and get some fresh air and a glass of water than to keel over and hit your head and hurt yourself. I have had several people faint during my events, and obviously I'm a doctor, so you know if that happens I know what to do, but there's nothing I can do over the internet. So please do take care, and if you don't feel well, just step out and step away for a little bit. No shame in that. I've had 6'6" rugby players feeling very unwell. So it can happen to anybody. So you've heard that I'm a pathologist, So what does that mean? So I'm a doctor, and I specialise in the study of disease. There are several different types of pathologist. I'm a histopathologist, which means I look at cells and body tissues, either with the naked eye or under the microscope. And I spend a lot of time looking at slides under the microscope to make diagnoses like cancer and inflammation and things like that. But post-mortem examinations, examining the body after death, are an important but quite small part of my role. People sometimes, you see television programs like, I don't know, Silent Witness and CSI, and think that it's all, you know, crawling around in ditches in the middle of the night looking for dead bodies and clues and things. Not like that at all. I work in a hospital, in a laboratory, and in the mortuary. I don't go outside to do my work at all. The ones you see, pathologists you see on television, are generally forensic pathologists. And we don't have very many of those in the UK because their job is investigating unnatural deaths, murders, and anything where there's something suspicious. And thankfully, we don't have very many murders. So we don't need very many of those pathologists to do the job. It's obviously a very important job when it's required. As a hospital pathologist, I would do post-mortem examinations on people who had died either in the hospital or at home. They would be brought into the hospital for me to do that. So post-mortem, and you'll have heard the word autopsy. We call this a living autopsy. They mean the same thing. Autopsy comes from the Greek word meaning to see for yourself. So it's to open up the body and see what was going on inside. And post-mortem are the Latin words for after death. So it means an examination that happens after death. But I will use them interchangeably because they mean exactly the same thing. And a post-mortem examination can range from anything from just an external examination of the body to have a look and see if you can find out what's killed somebody, through looking at all the internal organs, doing blood tests, or something much less invasive. It could just be a CT scan or an MRI scan to have a look at the inside of the body, and possibly with things like biopsies. So going through the skin to take a small sample of the liver or the lung, for example, to look at under the microscope, rather than opening the whole body up. But what I'm going to talk to you about today is the conventional autopsy. This is the standard one that most people who have an autopsy would have, and the others are more specialized and less common. So why would we do a post-mortem or autopsy after somebody has died? We certainly don't do it on everybody. There are about 500,000, so 500,000 deaths in the UK every year. And about 20% of those people who die will have an autopsy. The vast majority of them are done because the coroner says that it needs to be done. So it's a medico-legal examination to establish why the person died and what was wrong. And most of them are done because the doctors don't know the cause. And it may be that they didn't see a doctor for a long time. Perhaps they collapsed suddenly while out for a run or digging the garden, or were just found dead in bed. Or maybe they have seen doctors recently, but they were having a series of tests and investigations and they haven't quite made the diagnosis yet. Or sometimes a patient might have symptoms of 2 different diseases and it's not clear which is the one that has caused death. And so we might be asked to do a post-mortem there. There are also some deaths where we always do a post-mortem. For example, if somebody has died following an occupational disease, so say they worked in a coal mine or they worked with asbestos that has caused them to develop a cancer, then we would do a post-mortem examination to look into that. Or if somebody dies in custody, if that's police custody or in a prison, anything like that, we would do a post-mortem to make sure that there was no foul play. So why do we do post-mortems? Well, I've said to find out the cause of death, and that's probably the most important. They have many benefits. It gives you that cause of death, which is helpful to be able to register the death. So you need to know to get the death certificate so the death can be registered and so you can carry on and have funerals and everything. It helps the family to understand what happened to their loved one. If they can understand how the symptoms and what happened to that person in their last days relates to their cause of death. It's useful for family history. If you think about You know, what you're asked when you go to the doctor, is there any family history of heart disease? Well, you know, knowing the cause of death is really important to be able to say, well, yes, my grandfather had heart disease or my grandmother had cancer. It also helps healthcare staff to learn about disease. We train pathologists, nurses, we train the police because they have to deal with people who have died in what to look for and why we do a post-mortem. Obviously, we train students and pathology students so that they can learn how to do them themselves. It's helpful to be able to see the effect of treatment. If somebody's had a condition and they've been given a treatment for it, it's useful to be able to see what effect that treatment might have had. Useful for research, for looking into future cures for diseases like cancer or infection. We learned a huge amount about COVID-19 infection from post-mortem examinations. We started off thinking it was just a lung disease that gave people difficulty in breathing. And it became clear through post-mortem examinations that it affected the whole body. And that one of the main things associated with COVID infection was abnormal blood clotting. And it's that blood clotting elsewhere in the body that can cause symptoms and can contribute to things like long COVID, having long-term effects of that disease. Knowing causes of death also feeds into national policy. It helps, you know, the government and whoever's in charge of health to make decisions about where to invest in healthcare. If you know that heart disease is the most common cause of death, then you know it's worth investing a lot of money in trying to prevent that from happening. And so it informs that policy. So lots of reasons why we do a post-mortem. So let's have a look at the instruments that I use. These are the tools of my trade that I would use as a pathologist. So when I go to the post-mortem room, dressed up in all my protective gear, and I'd have something over my face to make sure I get no splashes in my eyes or in my mouth. I'm as protected as I can be. The first thing I'd say is that I don't do a post-mortem examination on my own. I work with anatomical pathology technologists who are highly skilled and trained specialists who work with us in the mortuary to do post-mortem examinations. So they'll do a lot of the preparatory work, they'll weigh the body, measure, make sure all the paperwork is correct, and then they'll help put things together again afterwards. But we work very closely together as a team. So when I walk into the mortuary, I don't go straight up to the body, I go to the paperwork. As with so many things in life, you have to make sure the paperwork is correct first. And so I would have a look and find out what's the story behind this person's death. You know, it makes a difference as to the likely cause of death, depending on what the conditions are. You know, were they in a car crash? Were they found dead in bed? Did they die in hospital having been there for a long time? So I need to know the history. I need to know what conditions they've had in the past, so that I can put that together with what I find on the inside. And also whether there are any particular concerns. If the police are worried, for example, that somebody else might have been involved, it's helpful to know as much as possible before I do the post-mortem. I then check that I've got full consent to carry the post-mortem out. Obviously, I wouldn't want to do it if I hadn't got consent. And that would come from either the coroner, if it's a coroner's case, or the next of kin, if it's a post-mortem that I'm doing for the family's information. But as I said, mostly it's for the coroner. So I check I've got all of that. And then I would go over to the body. And again, the first thing I check is the identity. So people would normally have a wristband, like the sort that you get put on when you go into hospital, with their name, their date of birth, and all their details. And I would check those against the paperwork that I've got. And then I can examine the body. And I don't reach straight for my scalpel. I have a look at the outside of the body because there are a lot of clues that you can get just by looking at the body. And so it would be laid out on one of those steel tables that you saw in the picture that I showed. And it's a bit like the way if you go to the doctor, they might have a look at you, they might have a look in your throat, your eyes, have a look at your hands, your legs. I could do the same thing when somebody's had having a post-mortem examination. So I would have a clipboard and make my notes as I go along, and I would check, the hair colour. Eye colour is a bit tricky after death because the colour of the eyes can change slightly, but I try to look for any identifying marks. If somebody's got tattoos, if they've had a leg amputated, if they've got scars from having their appendix out or something like that. I would record all of those, which helps to go towards identifying the deceased. I then have a look for any signs of active disease. So I'd look to see if the fingertips were blue and the area around the mouth was blue. That might suggest that the person didn't have enough oxygen before they died. I'd look for any injuries, any cuts or bruises or anything that could indicate what was going on under the skin. Have a look for swelling, swelling of the arms or legs or abdomen, for example. Have a look in the mouth, have a look at the state of the teeth and see if there are any tablets or food debris or anything around the mouth, and so on. So I do a full external examination, and really importantly, I roll the body over to have a look at the back. I don't think it's a true story, but there are rumours that a pathologist once missed a stab wound in the back because they didn't look. But I think that's just made up to scare pathologists and make sure we do a thorough examination. So you would look at the front and back of the body as closely as you could and document all of that really carefully. And then we can turn to our instruments. So I've got my instruments here on the table. And the first thing I use would be my scalpel. This is a disposable one. It's got a plastic handle and a very small little sharp blade on it. So it's only an inch or so long. And this I would use for opening the skin. So it's very sharp. And I'd cut from about the level of the little dip between the collarbones. If you feel your collarbones, there's a dip. So I'd cut from about there and cut the skin all the way down to the pubic bone. So really sort of top to bottom of the main part of the body. Being careful not to cut too deeply. Up here, it doesn't matter too much because you've got bone on the chest, but once you get to the abdomen, I don't want to cut into the guts and the organs. So just making sure I cut just through the skin. And often the anatomical pathology technologist, the APT, will do this part of the procedure. Once you've opened up, what we see under the skin is fat. And you can see, obviously, different people have different amounts of fat between the skin. It could be just a millimetre or two, or it could be quite a lot. And so we cut through the fat down to the underlying bone or muscle. Then using that scalpel, but also using some forceps, and I'll just show you those instruments. Okay, so forceps are like giant tweezers. So they're good for gripping things. And I've got two different types here, and I'll explain to you how they work and how they're different. So this is toothed forceps, and they've got a little hook on the bottom. These would be no good for plucking your eyebrows, for example. They've got a little hook on the bottom that goes into a little opening, and they grip really, really strongly. I haven't got a bit, I've got a sponge here, so I'll demonstrate on this. If I grab a bit of the sponge and pull, I can tell you now that bit of sponge will come away. So it's taken a bit of sponge away with it because they grab so strongly. Now, generally, we don't want to use these in people who are living because you don't want to damage things. So, you know, if I was moving a blood vessel out of the way during an operation, I wouldn't want to use these because if you pull too hard, the forceps wouldn't let go, but it might damage the blood vessel underneath. And that's where these forceps come in. These would be better for plucking your eyebrows. They come together, but they don't have those teeth of the other ones. So they're called non-toothed, and they're smooth. I mean, they've got a little bit of a ridge, but you know, nothing getting in the way there. And with these, I just ruined my sponge again. If I grab hold of the sponge and pull, it will pull away before it damages the sponge in there. So it's smooth and it will slip away. And what that means is that it won't damage any of the structures. So I would generally, obviously, if somebody's dead, you're not worried about tearing a blood vessel. But even still, we never forget that the person we're examining is a human being, an individual, somebody's loved one. And we never forget that. And so we treat the body with respect and dignity at all times. And so we don't want to disfigure it in any way that we, you know, so I would use these non-damaging forceps. And so I would take hold of the skin And then I could just cut away gently underneath with my scalpel and peel the skin back. And so what happens is you open up the skin a bit like sort of opening the pages of a book to reveal what's underneath. And what's underneath in the chest is the rib cage. So I can see all the bones of the ribs with the muscles in between them. And obviously I want to be able to examine the heart and lungs, which are protected by the rib cage, but I'm going to need something a bit stronger than these to get through to do that. So the instrument I use, that is this one. These are called rib shears. So these are like a giant pair of scissors. They've got a special curved end, and they've got a very long handle. So those of you who remember your physics will know that by having a longer handle, it means I need to use less force to be able to cut through something. If I had a very short handle, I would really struggle. But with a long handle, I need less force to cut. And you can see this curved bit here. This goes underneath the rib. So if you think about your ribs, have a feel, I pop it underneath one rib and then cut through it. And then I take it out and I put it under the next rib and cut through it. And I do that all the way up on both sides of the body towards the side. So I'm sort of going down the sides of the body like that to take out the ribs. And then I would use my knife, my scalpel, just to cut any little connecting bits of ligament or bone or anything, or muscle, to be able to take the front of the ribs off the body to expose the heart and lungs. And we call that piece of rib, which has the sternum, the breastbone in the middle, and then the start of all the ribs coming off it, we call that the rib shield, because it looks sort of shield shaped. And we put that to one side. Now, in strong, fit men, if I'm doing the post-mortem, it might take quite a bit of effort with those rib shears to cut through the bone. However, in older women, for example, who've got thinning of the bones, a condition called osteoporosis, the bones of the ribs can be so thin that I could cut them just with a pair of scissors. I don't need anything like those rib shears. So you get a lot of variation in the hardness and the amount of calcium and boning in those bones, depending on the person that you're examining. And obviously, the majority of people we do a post-mortem examination on are older because they have died. So once I have removed the front of the rib, it exposes the heart and the lungs. But before I remove any of the organs, I want to have a look around them to see if there's any fluid. And by fluid, I'm looking for things like blood. So has there been bleeding, for example, around the heart? Or is there a collection of fluid, which you sometimes get around the outside of the lungs? And similarly, I'd look in the abdominal cavity. So I'd cut through the muscles that are covering the abdominal organs and again, open those up so I can see all of the intestines and the abdominal organs there and see if there's any fluid there, because sometimes you can get a collection of fluid around those organs. And I would remove that fluid. For that, I would use ladles. Now, they look like the sort of ladles you might see in a kitchen for ladling out soup. And to be honest, they're really very similar. There's nothing particularly special. They're just scientific grade ladles. And what these have on them, unlike a soup ladle, it says on them exactly how much one scoop of the ladle is. So on my little one here, it says 120 mils. So what that means is I don't have to find a container and measure the amount of fluid around the lungs, for example. I can just scoop. So I know if I have one scoop of fluid, it's 120 mils, or if I have two scoops, then it's 240, and so on. So it allows me to be able to measure the volume of fluid around the different organs, and then that gets written down on my notes, and I can include it in my report. So they're quite useful. Then it's time to remove the organs from the body. And you might think that we take each organ out one at a time, but in fact, we don't. There are slightly different methods for taking out the organs. I prefer all of them to come out in one go. and then they are moved to a dissection table away from the body where I will dissect them and look at them in more detail, but I don't cut them up while they're actually in the body. So to get the organs out, I need another knife, and I use this knife. It's a PM40, a Post-Mortem 40 knife. I'll just take the guard off it. So you can see, I'll just compare it to my Scalpel. So Scalpel, there they are next to each other. Scalpel's tiny, this is a much bigger knife. So this is much sturdier. The Scalpel's good for doing delicate work where you have to be careful and you don't want to make very big cuts. So it's quite good for cutting the skin because you want to be careful that you don't cut too deeply. This is better for making big cuts, removing whole organs and so on. Okay, so I mentioned that first incision in the skin that's going from here down to the pubis. What I didn't mention is two other incisions that are made that make it easier to remove the organs and to examine the neck. And so those incisions would go from the first one along the collarbones and then up the side of the neck to behind the ears. And then I would use the scalpel and the forceps to gently and carefully peel the skin up to reveal the structures of the neck. And it's important for two reasons. Firstly, it means I can examine those structures in the neck, have a look at the muscles, see if there's any bleeding or damage, because sometimes if somebody's either been injured or somebody's hurt them, you can get damage around the neck. So if somebody was strangled, for example, you might expect fingerprints in the skin for bruising. You might see, or if you can't see it on the skin, you may see it in the muscles underneath, may get some bleeding, and you may even get damage to the voice box, which can indicate that somebody's been strangled. So obviously that doesn't happen very often. And if I were to be suspicious that somebody had been strangled, I would stop doing the post-mortem immediately. And that's when the forensic post-mortems who specialise in murders would be called in, because that's beyond the scope of what I do. But I examine the neck carefully. But the other reason that we expose the neck is to make it easier to remove the organs of the neck. So I would take my PM40 knife. I'm going to put the cover back on it, just because I don't want to get carried away. If I'm demonstrating this on myself, I don't want to start poking myself in the neck with a knife. Okay, here we are. And having peeled up the skin, I then cut just underneath the jawbone. If you put the knife up here, it will go up into the floor of the mouth. And so I cut round here, round the jaw, and what it will do is release the bottom of the mouth. And so I can put my hand up here and get hold of the tongue and pull it out. And then I use this knife to cut along the back while pulling the organs out. So I have the tongue in my hand and I pull, and it will come along with the esophagus, the tube, the gullet where the food goes from the mouth down to the stomach. There'll be the trachea, which you can feel in your neck, which is the tube that the air goes, the windpipe. So air goes down into the lungs. And if you feel it, you can feel the little cartilage rings which keep it open so that it doesn't collapse down. So it's permanently open. I think I'll show you a picture of that a bit later on. And so they will come away and I'll use my knife to cut behind them. And then I get down to sort of this level, and then the lungs will start to come away, and then the heart, and I carry on all the way down. And then I get to the middle, the bit between the abdominal and the chest cavities, and I reach the diaphragm. And the diaphragm is a domed muscle that sits between the two cavities, and that's what enables us to breathe, with the lungs above, and the diaphragm moving up and down will help the lungs to expand and contract with breathing. So I have to cut the diaphragm, and it's connected all the way round the rib cage, front and back. And so I would use my knife to cut inside the rib cage to remove the diaphragm. Then I can continue with my big block of organs, which is now tongue, trachea, esophagus, both lungs, the heart, what's left of the diaphragm, and I carry on cutting, and I will take the liver and spleen, which I'll come on to a little later, all of the intestines, and then cut down, taking the kidneys, the bladder, and then in a woman, I take the uterus, fallopian tubes and ovaries, and then cut down at the bottom. And so I've got my whole set of organs from the mouth to the anus, really, all in one big block. And that would go onto my side table for examination in a minute. And I don't step away from the body just yet. I want to have a look in the body cavity to see if there are any clues there. But often there's a bit of blood about, as you might expect. And that's where my sponge comes in that I've been pulling apart. The sponge is really useful for wiping the cavity so that I can have a look and just see if there are any lumps, scarring, tumours, anything like that that's in the body cavity, and we'll remove it with that. Okay, so I'll probably step away from the body now and have a look at the organs on my table. And to open the organs, I have some more instruments. So I still use my scalpel and my PM40 for doing cutting. They're just good for cutting things. But I also have a couple of pair of scissors. And here we are with this pair, again, quite a long handle and quite a short end. And this pair of scissors is slightly curved at the end. And you might think I just cut the way you'd cut a piece of paper, but actually what we do with the scissors is something we call blunt dissection. So I don't want to damage anything until I've had a chance to examine it properly to make sure that everything's in the right place and nothing's gone wrong with it. And if I start cutting, then I don't know if it was me who cut through something, or did the surgeon cut it, or had something happen to the patient, did it burst? So really important for me not to damage anything. And what blunt dissection is, I put the scissors in, and instead of putting them in open and closing them, I put them in closed, and then I open them. And what that does, it pushes tissues aside along the natural tissue planes, so along the lines that they would separate normally. And it pushes them. And if something doesn't want to go, it just won't go. And the scissor will open more on one side than it will on the other. But what it means is I don't damage anything. And surgeons use this in the living often when they're looking inside the abdomen or somewhere and they don't want to cut through things. So blunt dissection is a really useful technique for pushing things apart without damaging them. So one of the things that makes examining the organs quite difficult is the presence of all the intestines. So we have a lot of intestines. We have the small intestine, which comes off the stomach. So our food goes into the mouth, down the esophagus, into the stomach, gets squelched up and mixed with enzymes and acids and things. Then it goes out into the small intestine. Now, small intestine can be between 6 and 7 meters long. So it's really long and it's all coiled up. It's about an inch or so wide. It's like a long tube, like a long sausage. Then that goes into the large intestine, the colon. Starts on the right-hand side of the abdomen down towards the hip, and then it comes up across the middle, down the other side, and then round the corner and out through the anus. And the large intestine can be up to 1.5 meters long. So the whole gut, which is from the mouth to the anus, going via esophagus, stomach, small intestine, large intestine, can be up to 9 meters in length if you laid it all out. So it's quite a lot of stuff all coiled up inside there. And to be able to examine the other organs, particularly the abdominal ones, I want to get the bowel out of the way so that I can see what's going on. So the way I do that is I would tie a piece of string at the junction between the stomach and the small intestine. So I'd loop it round and tie a piece of string and then cut it off. And what that does, the string, it just stops the contents of the intestine pouring out. So I've got it tied with a piece of string. Now, the bowel it's just not like a hose pipe that's sort of all coiled up. It is attached in various places to something called the mesentery. So it's like a sort of a fan of fat, and it has blood vessels coming up. And then the bowel is attached to it at this end, making sure it gets all the blood supply that it needs. And then that's all coiled round and round. So I need to remove the bowel from the mesentery, and I use my trusty PM40 for that. So I would hold up the end of the bowel that I've tied with a piece of string, and then just cut close to the bowel. And as I cut through the fat, which is quite soft, and it comes away, leaving me with the sausage of the long bowel. And I do that. It's a bit like playing the violin. and my length of bowel is getting longer and longer, and I'm cutting away like this until I've taken it all out. So the small bowel will come away like that. The large bowel is quite stuck down in places to the back of the body cavity. And obviously I've had to cut through some of that to take it out. So, you know, when I'm removing the organs, I'd have to cut around the large bowel to take it out. Then I would open the bowel with scissors, similar to these ones. And these are a special type of scissor. They're called a bowel scissor. And if you have a look at that, you see the top is like normal pair of scissors. The bottom bit is longer than you would expect. It goes on a couple of centimeters longer than the top piece, and it's got this funny little lip on it. And these are special scissors for opening the bowel. It's called an enterotome, or bowel scissors. And what this does, instead of, if I show you the normal scissors, if you think of the bowel as a very, very long, bit like a sausage skin, long tube, but remember it's quite wet and moist, so it's sticking to each other, so it doesn't stay completely round, you know, it sort of can go quite flat depending on how much is in it. Cutting it with normal scissors can be quite tricky because you'll do a snip and then, you know, you'll lose your place and you have to open it up again and put it in and cut a bit more. What this bowel scissor does means that if you put it into one end of the bowel and start cutting, this bit here will always keep the next bit of bowel on your scissors. So you're not worrying about just doing a snip. You can just carry on. And so rather than taking small tentative cuts, you can hold the bowel and just go like this all the way along. So it keeps it open, and this lip sort of presents the next bit to be cut. And so they're really useful for opening up the bowel. So we'd have a look in the bowel and have a look to see if there was anything abnormal. Looking for things like tumours. Bowel cancer is quite common. I'd also look for any inflammation, because you can get inflammation of the bowel is common, inflammatory bowel disease, Crohn's disease you might have heard of, ulcerative colitis. I'd look for any ulcers, polyps, which are little growths. So anything, I would look for the contents and see if there was evidence of blood or something else like that. But once I've opened the bowel, washed it out and had a look at it, I can put that to one side. And then I can focus on the rest of the organs. And generally, for the rest of the organs, I would use my forceps to hold things out of the way, and one of my two knives for cutting after I checked that all the anatomy was correct. Now, we do the same post-mortem examination on everybody, the same basic examination. So I don't just focus on the bit that I'm worried about. We do the same for everybody. But I would tailor it depending on what I found. So if I found some blood in the stomach, obviously I would want to look more closely to find out where that had come from. Or if I find a tumour in the bowel, then I would want to look at that, and I'd want to look at the places that we know bowel tumours might spread to, like the liver, more closely. But you know, 90% of the examination is exactly the same for everybody. And the bit that is really important not to miss out is the head. So I've been talking a lot about the internal organs from the chest and the abdomen, but what about the head? The brain clearly is a vitally important organ, and it's one that's commonly linked to a cause of death. Causes of death like strokes are quite common, and many people have brain conditions such as dementia, maybe Alzheimer's disease, Parkinson's disease, and so on. So it's really important to look at the brain. But this is where it gets tricky. So this is plastic. It's not a real one, but it's a plastic skull, but it's a very good replica. And clearly, the difficult thing about getting at the brain is the skull. It's intentionally there to protect our brain, and the brain itself hasn't got very much to protect itself. It hasn't got it's very soft. It hasn't got ligaments or muscles or anything else apart from this bony covering. Which is why this is so tough to get through. So that's our next challenge, is to remove the brain, and then we can examine that. So we need a saw, and we can use just a very basic handheld saw like this, the sort you might get at a hardware store. And we'd use that to cut like this around the top of the skull. increasingly nowadays, most people have a vibrating and oscillating saw, a bit like the type that takes off plaster of Paris if you have your arm in plaster, if you break it. And they use that, and that cuts through the bone. Some people prefer to use the handheld saw because you may have a bit more control over it, and it makes less of a spray because you don't want to breathe in bits of bone. But most people would use that vibrating saw. And so you would cut around, and so we cut around the front of the skull, but it's not like taking the top off an egg. We're not going to cut all the way around the top like that. What we would do is cut from about here round to the other side. What I forgot to mention, of course, is how do we get to the skull in the first place? Silly me. So we've got to get the skin off the top of the head. I'd use my scalpel to make a cut. I'd go from behind one ear to behind the other ear, and then using my scalpel to carefully cut, peel the skin forward to the eyebrow and peel the skin back. And that would reveal the bony top of the skull. So we've done our cuts then from around here, round the front to the other side. And instead of carrying on round the back, what we actually do is cut up at an angle. So more like that. So we go from straight round until we get to about the ear, and then go up at a bit of an angle. And in a minute, I'll show you why we do that. But once we've cut round, the top of the skull doesn't just come away. It's got lots of membranes holding it down onto the brain. And so we have to prise the top of the skull off. And this is where I need more hands than I've got, I think. So I will try to explain this with what I've got. And for that, I use this, which is just a mallet, nothing very fancy. And this, one of my favorite instruments. It's called a T-chisel or a skull key. And I'll show you that. So it's T-shaped, and this end of it has got a sort of little chisel wedge shape. And what I do, not enough hands, is put that into the gap that we've cut with the saw and just give it a little tap. And that just pops it into the gap. And once I've done that, I can twist it, which is why it's like a key. So obviously this is plastic, so it's a bit different, but it twists and you can move it round and twist. And this makes it easy to grip. And the sharp end makes it easy to fit into a small gap. And as I twist it, it will tear away the membranes that are holding the skull down on the surface of the brain. And I do that all the way around, and then I can take the top of the skull off to reveal the brain. So here's the brain. It doesn't just fall out. We have to use a scalpel to cut really carefully all the places where it's connected to the top of the spinal cord. But I'd have a look over the top, over the surface, to see if there are any abnormalities first. So I'd have a look inside the skull, top of the skull that I'd removed, looking for any tumor, bleeding, anything like that. And then similarly over the top of the brain, looking at the different layers of the membranes. So there are several layers of membrane. There's a layer that's stuck to the bone, and that's come away with the bone. Then there's another layer over the top of the brain. And so I might have to cut through that to reveal the brain underneath. And I'm looking for blood. Bleeding around the brain is bad news. It causes a stroke if it's either on the surface or inside the brain. I'd look for pus. If you've got inflammation and pus on the surface, it might suggest the person had meningitis, inflammation around the brain. And then I'd remove the brain. So I do those few cuts and then roll the brain out. Now, I like to watch pathology programs on television and crime programs and things. I know not all pathologists do, but I do. I like to watch Silent Witness and all those sorts of things. But the one thing that makes me shout at the screen more than anything is the way they treat the brain. So often they'll take a brain out and they'll hold it up like this and say, oh yes, you know, clearly they died of whatever it is, disease. If you did that with a brain that you've just removed from the body, it would just fall around your arms and onto the floor. The brain has a consistency more like a jelly or a set yogurt. If you think of a Greek yogurt, you know, so I can just about pick it up in two hands like that if I'm very careful. If I put it onto a hard surface, it will start to spread out. But if I were to hold it and squeeze, my fingers would go straight through it. It's not a firm, hard organ. The ones that they show on television, which clearly aren't real, would have to have been pickled in fixative for about 3 months to be able to enable them to hold them up like this. So the brain is really soft. And that's because, as I mentioned, it's got nothing to protect itself. It hasn't got ligaments or muscles or all those things that make things a bit firmer. It has neurons, the brain cells, and they're covered in fatty substance. And so really it's fatty. It's very fat, but very soft. Your fingers would go straight through it. So I'd have a look at the brain and I would slice the brain to see if there's anything on the inside of it. And again, I'm looking for bleeding. I'm looking for fluid buildup. There are some cavities inside the brain. And if you get too much fluid, those cavities get bigger and bigger and they compress the brain substance around it, because of course the brain has nowhere to go because it has the skull over the top of it. I'd look for tumours. There are lots of sorts of different tumours you can get in the brain, either ones that have grown there or tumour that has spread from somewhere else in the body. So I would slice the brain, and for that I use a brain knife, which looks a bit like a bread knife because it is really very similar. And so I would slice the brain at about 1 centimetre intervals all the way along, looking for any anatomical abnormalities, bleeding tumours, lumps, cysts, anything like that. So I'll just put that down. Once I've done that, the brain is a mess really, because it's all disintegrated. So there's no way you could put it back together. But I'll put the brain to one side. And now I can have a look at the other organs that I've dissected off properly. So the heart is probably the organ that I would examine next, because heart disease is such a common cause of death. So although, as I say, we do the same post-mortem for everybody, I do like to look at the heart first, so I know why the person's died. So I'd have a look at the outside. I'd have a look at the blood vessels that supply oxygen to the heart, because if they get blocked, that can cause a heart attack. I'd look to see if there's any blood in the sac that the heart sits in. And I'd have a look at the muscle to see if the muscle was working and to see if there's any scarring. I'd then have a look at the lungs and see, is there any carbon deposition? Might indicate that the person was a smoker. It might suggest they lived in a very heavily built up city and they were breathing in a lot of pollution. I look for tumours, I look for infection, as the person got pneumonia, for example, which is quite common. I'd have a look at the abdominal organs, the liver, which sits under the rib cage on the right. Our biggest internal organ, weighs about 1.5 kilos. And you can't normally feel it. It's hidden by the ribs protect it so it doesn't get damaged. On the left, we have the spleen, which helps to keep our blood clean. It has a lot of purposes. That weighs about 170 grams and again sits under the rib cage on the left. Then we have the kidneys. We have 2 of those. They sit towards the back of our body. They weigh about 140 grams or so, and they help to make the urine. Then we'd have a look at the bladder, the uterus in a woman. So what I'm going to do now is share my screen and just show you some pictures to illustrate what I've been talking about. So we've seen all of the instruments. So now I'm going to talk to you about the organs. So that's just a reminder of where this incision is, top to bottom at the front, and then out and up the sides of the neck. And we would cut through the skin. So you can see here, the skin's very thin, a couple of millimeters, but underneath you've got quite a thick layer of fat. And so I would open up the skin, peel it all back, and it would reveal, the rib shield has been removed here, and then it reveals all of the internal organs which can be removed. And we take them all out in one go. So I mentioned the heart being probably the most important organ. On the left, there's a diagram, and on the right, that's a picture of what a real heart looks like. They say your heart is about the size of your fist, but actually I think it's about the size of 2 fists, having seen a lot of them. You know, if you put one fist round the other, I think that's probably a more realistic size and shape for your heart. So the bigger you are, the bigger your heart is. And we have tables that tell us how big the heart should be, or what a normal range is, depending on the size and age of the person. What the diagram on the left shows, really importantly, are the blood vessels that take oxygen to the heart. Our heart is a muscle. It beats from when we're in our mother's uterus all the way till the moment we die. So it's the most active muscle in our bodies, and it has to keep going and going all the time. But to do that, it needs energy, and blood vessels bring the energy, the glucose, the oxygen that the cells need to contract. And if that supply of energy gets cut off, then your heart is in trouble. And if we were to cut across the heart, across the bottom bit, we can see that the heart has got two cavities towards the base. So it's got two at the top, the atria, right and left, two at the bottom, the ventricles, right and left. This section of heart here that we cut is not brilliant, but what I want to show is that the left side of the heart is generally a bit bigger and the muscles a bit thicker than the right side of the heart. And this is why. You'll probably be aware of how the circulation works. So let's start with the lungs up at the top. So oxygen in the air that we breathe in gets to the lungs, and it is transported from the air sacs in the lungs into our blood through a very fine barrier. And that's the whole point of the lungs, is to get oxygen into our bodies. That blood then leaves the lungs and goes into the heart on the left-hand side. And it goes into the atrium, which then pumps it through into the ventricle. That's the big muscular chamber of the heart on the left-hand side. And it's big and muscular because that then has to pump the blood around the entire rest of the body. So blood leaves this left atrium, comes out through the aorta, goes up to the head, down to the rest of the body. And there's branches of the blood vessels go off to the arms, the legs, the gut, everything. And then once it gets to where it needs to go, the oxygen from the blood is taken out and it goes into the tissues where it's needed. So it helps to keep our muscles working when we're exercising, helps to keep our gut working, and so on. And so the blood then starts to lose its oxygen. So you'll see it's red on the right-hand side. And it passes through capillaries and then into the venous system. And the blood in the veins, it's not actually blue, but it is a darker red than the bright red oxygenated blood. So, and it looks blue through the skin. And the veins then take the blood back to the right side of the heart. And so they come in here to the right atrium, through into the right ventricle. It's still muscular, but not as muscular as the left, because all it has to do is pump blood to the lungs, which are right next door. So it hasn't got far to go. So it doesn't need to be as strong as the left-hand side. And so this blood that's now given up all of its oxygen goes into the lungs, where it picks up some more and then starts the journey all over again. So it's a very, very clever design for making sure that the blood is pumped to the body where it's needed and then back to the lungs to pick up more oxygen. This is an example of a heart that's too big on the left. So I said it has to be big and muscular, but over here, the left ventricle wall is so thick that there's hardly any room for the blood. And this is something called hypertrophic obstructive cardiomyopathy. What that means is overgrowth of the muscle of the heart in an abnormal way. And this is something that can cause young people, athletes particularly, to suddenly have a cardiac arrest. And you're probably aware there's been a couple of footballers who've had cardiac arrests on the pitch. Thankfully, they've been resuscitated and they're back to good health. But young people who collapse with abnormal hearts sometimes have this condition, which is why there's a campaign for young athletes particularly to have their hearts checked out to make sure that they haven't got this. Because what can happen is the heart will suddenly stop because it just can't pump any blood around the body. And there's the right side, bigger hole, less muscle. So it's this left side that we're worried about. So I mentioned that a heart attack is a really common cause of death, and that happens when you're not getting enough oxygen to the muscle of the heart, so the heart can't beat properly. And if you think of those blood vessels supplying the oxygen, it's a bit like pipes, like central heating pipes, and they can get furred up with deposits. So on the left, we've got a picture of a normal artery. In the middle, we're starting to get fatty deposits within the wall. So you can see the hole down the middle where the blood goes is getting smaller And as you move to the right, it's got smaller still. This can easily get blocked either by more deposit, or one of these deposits can sort of fall apart and block it, or you can get a blood clot in the middle. And then that stops blood getting to the rest of the heart, which can start to kill it off. This is a picture at post-mortem examination. I know it's quite difficult to see, but in the middle, you see a round thing. What that is, that's a cut through the coronary blood vessel, the artery, and the dark red stuff, that's blood clot in the middle. And so it's completely blocked off the blood supply past that point. So if you look at our diagram again, you've got blood coming down here, and then the little black line, that's where you've got your clot. And everything beyond that will then be starved of oxygen. And depending on how big that area is, you might just get some chest pain. If it's a tiny area, you might have a full-blown heart attack and be able to get medical help to try and fix it. Or if it's massive, you may die from a heart attack because of it, depending on the extent. I know I'm running out of time, so I'll speed up. Here's an example of a heart attack. On the left, you've got the smaller right ventricle. Over on the right here, this is the left ventricle, and far right, you've got bleeding. And this is an area of the heart that had its blood supply cut off. This is just a picture of a tiny heart, but anatomically perfect. This is from a 12-week fetus, so still in the mother's uterus. You can see the size compared to a 5p piece. This is a modern 5p. So it's only a few millimeters in size, but you can still see all of the vessels, the aorta, the branches, the atrium, the ventricles. They're all formed really early on. Quickly to have a look at the lungs. Perfect lungs should be pink and spongy, but not all of us live in perfect conditions. So there's likely to be some black discoloration just from pollution. But if you smoke, you may get much more of this. And of course, you're predisposed then to lung diseases such as lung cancer and obstructive lung diseases. And so we can have a look for those as well as infection. Looking quickly at the gut, I mentioned the small intestine, 6 or 7 meters, and then the large intestine going over from, this is the bottom right-hand corner, and there's the appendix. So if you've had your appendix out, it's at the start of the large intestine, and then all the way around the corner and out. This is the liver. I mentioned our biggest organ, should be smooth and shiny. This little green thing just underneath is the gall bladder. We store bile there, which helps to break down fat in our food. If the concentrations are wrong, you can get stones in the gallbladder. Some of the material precipitates out and forms a little stone, and then it can get bigger and bigger over time. It doesn't cause many problems if it's sitting in the gallbladder, but sometimes it starts to move. And if it gets in the neck of the gallbladder, it can block it off, and then things build up behind it, and then you get pain. So a lot of people have their gallbladder taken out for that reason. This is a liver with cirrhosis, which you may have heard of, which is a scarring of the liver. The liver gets scars and it tends to get smaller and smaller. It goes a bit lumpy like this. And this is irreversible. Once you've got this, you can't reverse it. Causes include alcohol, probably the most common cause, but also some drugs can cause it, or there are autoimmune conditions where the body's own reaction to its own cells can cause damage. That's just to demonstrate that angle for taking the top of the skull off and the brain. And I mentioned the different layers, and I don't want to give you a full anatomy lesson, but it's just to explain the different layers. Up at the top, we've got the scalp, the skin, and down at the bottom, we've got the brain. This is the sort of the typical white foldy brain. And in between, we've got several layers. We've got the bone, then we've got one of our membrane layers, which is stuck to the bone, and then another membrane layer is stuck to the brain with a space in between. And you can get bleeding at various levels. If somebody has a stroke, normally it's bleeding within the actual brain itself, but sometimes you can get bleeding into this space, the subdural space, or sometimes into this space here, the subarachnoid space. So if you hear people talking about subarachnoid hemorrhage or subdural hemorrhage, it just relates to different levels, depends which membranes it's between. So a really important part of the postmortem that I cannot miss is the reconstruction. That's putting everything back together. So you'll remember we had that cut that went up to the middle, along to the side and up. The reason for that is because once you finish with the postmortem, all of the organs which have been cut up would go back into a bag, and then that would be rolled up and put into the body cavity. You can't put the organs back exactly where they came from because I've already sliced them all up. We'd then put the rib shield back so it fits right back into place, and then close the skin around it and sew it up. But when you get to the neck, the stitches would obviously come along the side and up the back. And that's so that if the family want to view the body, then they can't see any of the stitches. So if they've got a shirt on or a shroud, the stitches are behind the level that you can see, and they go behind the ear. So we're always thinking this is somebody's loved one. They may want to view them. They may want to have an open casket. And so it means that they don't have to see that. The cut in the brain, we'd close the skin up across the skull and sew it up. And because that incision was from behind one ear to behind the other ear, when it's sewn up, in somebody who's got hair, you can't even tell that it's been open. But even in somebody who's completely bald, because of the position, if you put that head on a pillow, you can't see it. So the person has no evidence when somebody comes to view them after a post-mortem that they've actually had the examination done. The APTs particularly are very careful about reconstructing bodies to make sure that they look as good as they possibly can. And some families say that they look better after the post-mortem than they did before. They will be washed, the hair would be washed, and they'd look as presentable as they possibly could. And the future of post-mortems, just quickly to finish. So I've been explaining that at the moment we open up the body and we have a look at things. The future is probably scanning, or a combination of scanning and biopsies. Part of the problem with not being able to do this at the moment is it's very expensive. We haven't got spare scanners. There's a long enough queue for people who are alive waiting to have scans, so we can't take them over to do scans for the dead. It's a special thing to have to learn to be able to interpret these scans. So we would have to train a lot of radiologists, X-ray experts, and pathologists to be able to interpret them. But I think it is the future. So this is a scan of somebody who's died with something wrong in their chest. Here's the vertebra, the spine at the back of the chest. These empty black areas here are the lungs. They're full of air, which is why they look black. This is the heart. You can see it's sort of vaguely heart-shaped. And the star indicates the cause of death. And this material around it is blood. And this person has had a heart attack, and it's damaged the wall of the heart to such an extent that it's essentially burst, and blood from the inside of the heart has tracked out to surround the heart. And when that happens, every time the heart beats, it puts blood into the sac surrounding it, which gets fuller and fuller, and it compresses the heart and stops it from beating. It's called cardiac tamponade. And that's a very definite and obvious cause of death. Here's another one. This is the skull. At the front, these are the eyeballs. There's the nose. And this white area is bleeding into the brain. And this person's had a stroke. And so that's another obvious cause of death. They're not always that obvious, but for many causes of death, scans, I think, will replace invasive postmortems in the future. I hope you've enjoyed today. I often get some nice feedback. This is somebody said, really enjoyed it. And, you know, it's confirmed that I really want to be a clinical biochemist. That's another sort of pathologist, but not everybody enjoys it. You know, I get the odd comment like this, but I can live with that. So I'm very happy to take any questions. I'll have a look in the Q&A. I'm going to stop sharing so that you can see me and have a look and see what questions you've got. Okay, so if you've got time, I'll just go through the questions. Somebody asked, what's the strangest thing I've had to remove from a body? I often get asked that, or what's the weirdest cause of death, or something like that. I'm trying to think. To be honest, I'm not sure I've seen anything really weird. I know you sort of go to museums and you see all these strange things that have been removed from bodies, and you hear all these awful stories. Probably the strangest thing is probably a sandwich, somebody choking on a sandwich and actually being able to take it out of the windpipe and being able to identify a bit of ham sandwich. But I haven't seen anything really weird and wonderful. Someone asked, how did I become a pathologist? How long did it take? Well, to be a pathologist, you have to be a doctor first. So obviously you need all the right GCSEs and A-levels, and then off to medical school. I did 6 years. Sometimes you can do it in 5. I did an extra year to study anatomy. So that took me 6 years. Then you have to be a junior doctor for 2 years, where you learn the basics. You'll do medicine and surgery and probably some general practice. And then you apply for specialist training. And that would be the same way you might apply to be a surgeon or a diabetes expert or a joint expert. You apply to be a pathologist, and that's another 6 years to do that. Sometimes people take extra time out to do research. They might want to do a PhD or do some research in a particular area, and that can add more years. So it takes a while. The good news is once you qualify as a doctor, you are getting paid. So it's not like you're a student forever living on a grant with no money. You do at least get paid as a junior doctor, and then work your way up to consultant through the different layers. So I've been a consultant for 22 years now. I mean, when I was a trainee, I thought it would last forever, but actually I've been a consultant for far longer than it took me to train. So it does take quite a long time. Is there anything I wish I knew when I began? Oh, that's a nice question. I don't think I've been asked that one before. I think probably, I mean, I hope I've done it, but to keep the importance of keeping an open mind and how quickly things would change. And, the post-mortem examination hasn't changed really in 500 years or 2000 years. There's a limited number of ways in which you can open up the body and have a look at things, but actually CT scans will change that enormously. And similarly in the majority of my job, which is looking at tissue from the living under the microscope, we now get a lot of help from special tests. We can do molecular tests. So I don't just diagnose a cancer. I can tell the doctor looking after the patient exactly what the type is, what the mutation is in the gene. I can say whether it's likely to run in families. I can say which drugs that tumor is likely to respond to. So I think if I had to go back, I'd just reassure my younger self that it was going to be a fascinating career with lots of new changes, but all improving care for patients, which is why you go into it. So it's always very exciting when something new comes up that means you can provide better care and a more accurate diagnosis. What's the hardest organ or tissue to work with? For me, it's the brain, partly because it's so delicate and it's really easy to damage things, but also it's such a specialized area. So we actually have specialist neuropathologists. That's pathologists who specialize in the pathology of the brain and spinal cord. There's not very many of them, but they tend to work in specialist centers. And if I get a tricky brain, I can diagnose quite obvious things like a big bleed or a big tumor. But if it's more subtle, so for example, somebody's got dementia, you can't necessarily see anything in dementia. I might want to send the brain off to the specialist neuropathologist, and they would look at it in much greater detail, and they understand how all the connections work and what damage to the different nerve cells looks like. So for me, probably the brain. What do I think makes a good pathologist? You've got to be curious, you've got to be interested. You've got to really want to help people. And some people think, well, that's weird because, pathologists don't see people, they don't see live patients. And isn't it for people who aren't good with, talking to people? But actually, everything we do is to benefit our patients, whether it's live patients who've had, a lump or bump removed, or somebody with cancer who's had a breast removed or something, or whether it's dead patients, being able to provide answers for the family, to be able to teach other healthcare professionals so they can provide better care in future, and just all that learning to help improve care. I would say you've got to have quite a strong stomach, but actually you develop that as you go along. So you wouldn't go straight for, at 18, you wouldn't walk straight in to watch a post-mortem. You learn the anatomy, you would do dissection on a cadaver to learn how it all works. You would go to surgery and have an assist, and so you could see the organs in place, and you build your way up to it over several years. So you don't go straight in, but you do need a reasonably strong stomach. If you can't stand the sight of blood, it's probably not the career for you. But natural curiosity and an open mind, I think, are necessary. Let's just have a look, see if there's any more come in. Great. What's the biggest misconception about pathology? Well, it's two things. One is that we only work with dead bodies, which we don't. Post-mortems make up about 5% of my week, 2 or 3 hours a week, and the rest of the time I'm working for the living. I suppose the other is that it's just like it is on television, which it isn't at all. I mean, I like watching those, but they're complete works of fiction and not remotely. And the other is the one about having no people skills. As a pathologist, there's no point being a brilliant pathologist and being able to make diagnoses if you can't communicate it. We have to be able to explain it to the other doctors so that they know how to treat the patients. So pathologists have to have good communication skills, not poor ones. Thank you. I know I've overrun slightly. Thank you for bearing with me. If you have any other questions, you're welcome to try and get them to me any way you can. I'm very happy to answer them. Thank you very much. Hope you enjoyed it.